This is a continuation video. So here is what you can see from in the umbilical artery in the normal conditions, and you can see if there is an IUGR or PE, then there will be a high systolic and reduced and diastolic. So the RI and PI will increase. And if the condition more deteriorates further, there will be absence in the end diastolic and even reverse of the end diastolic flow. So the cutoff point for the umbilical artery in the second trimester, usually we take the PI. Usually we take about 1.5 to 2. And the third trimester, we take 1.5 to 1 to 1.5 lah. That is for the umbilical. And for the RI, the resistance index, we take about less than 0.7 normal value. So let's see what happened in the middle cerebral artery. So we know now the circle of Willis, right? So we have anterior cerebral artery, we have the middle cerebral artery, and we have the posterior cerebral artery, which will form this circle of Willis. And this is the posterior communicating artery. So we are measuring the MCA here. The MCA. So the MCA basically shows a brain sparing mechanism that happen when there is an IUGR, because what happened is that the MCA will need vasodilatations when there is less oxygen. Then the MCA will try to accommodate with the low oxygen by having a vasodilatation so that they can supply more to the vital organ like brain, heart, and also the adrenal gland. Heart and adrenal gland. And vasoconstrictions at the periphery, which will be seen in the umbilical artery, because there will be less to the limb, less blood flow to the limb, and also to the kidney, renal kidney. So that is why usually in IUGR, the fetus will have an oligohydramnios. So due to this is what we call a brain sparing effects. So that is why you can see something different in the MCA. So and in middle cerebral artery also we're gonna take the doppler, and in a normal condition usually it does not need high pressure, and during the diastolic it does not need too much blood flows during the diastolic. This line is too high, too low. Okay. And then when there is a stressor, there will be the end diastolic will increase. The end diastolic will increase. So it will look something like this. And if the MCA is very low, that means the EDV is increased. So you have this kind of pattern, like a normal umbilical artery pattern. And please not happy with this. So it will be different in terms of the end diastolic. So that is why after 34 weeks, usually we take the cerebral placenta ratio, the CPR, where we divide the MCA PI divide by the umbilical artery PI, and we'll get if it's more than 1, then it has a very good value that this fetus is not affected. There is no brain sparing effects happen, so the fetus in still a tolerable condition, and you can basically delay the delivery a bit with the frequent monitoring. So there's another chapter of how to monitor a baby with suspected IUGR after 34 weeks using the CPR. So this is what happened in the MCAs. So what happened in another things that you can see is the Ductus Venosus here. So the value here, umbilical artery, the MCA, and also the DV. DV in abnormal baby, in abnormal fetus like this with the syndromic features, usually ductus venosus is one doppler is one of the scan during the first trimester, which you can combine with the NT, with the knuckle translucency. So combinations of knuckle translucency with DV will have a higher value of 70% of having a abnormal normal fetus. So if you the ductus venous is basically the measurements that you take the Doppler. It's the oxygenated bloods. It's a venous, so it has different patterns with the arterial. So arterial, we have something like this, but the venous, it has a different wave. So you can see something like this. So this is the systolic. This the diastolic. And you have the A wave here. A wave basically, so you have the what you call it, systolic atrial. So this one is systolic for ventricle, this one is systolic for atria, so you have the A wave. So usually the patterns that you can see like something like this. But in abnormal condition, you will have the absence of the A wave. Or it can be reversed. So no A wave. So negative A wave is a bad prognosis. And for the DV at the first trimester, if you detect this, you have to think of the aneuploidy. And if this develop later, then you have to think of the IUGR. And subsequently, you have to do, you have to scan another like the tricuspid regurgitations and also the umbilical vein, which will be explained later. So I hope, we forgot to talk about what happened after the delivery. So usually the ductus venosus will become the ductus arteriosus will become the ligament arteriosus. The ductus venosus will become the ligamentum venosus. The umbilical artery, we have two here, so it's become the umbilical ligament. The umbilical vein will become umbilical ligamentum teres in the liver. So this is all something that we have to remember for part 1. Thank you.